Yeah, it was.
All right, welcome. We have a guest here. Hi, Candace, Dr. Candace Vandenberg from Phoenix.
Yeah,
How's
well, I was gonna exercise and listen on, so I wasn't expecting to be on video.
Yeah, I thought you were Simon, and then you popped up as Dr. Simon Wong.
Yeah, it said I was a panelist, so I can hop off and
No, 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 you can mute and turn off your video, but welcome. Uh,
then I don't know why it says Simon Wong.
yeah, it's a bit strange. I don't know why, but it's all good. Hi, Simon. Can you hear us? See us?
Hello.
All
Hello.
right, welcome. All right,
Here,
welcome.
I'll get off.
Hey, Candace, I've never looked this good.
I
There we
don't
go.
know why it's when I logged in, it said I was a panelist, and
I
I was
must
like,
have tried to upgrade Simon. I don't know. Must have perfect timing, as they say.
"That's okay. Well, I'm happy to be here. I'm gonna shut the video off and
Okay, yeah, just mute out, and
okay, all
whenever you've
right,
got questions, unmute. All right, and join
okay."
us. Terrific. All right,
So I
welcome
don't know.
everyone.
It's okay that yeah, I'll just unmute it there.
Yeah,
Okay, thank you.
terrific. Thanks so much,
Thanks.
Candace.
Thanks.
All right, welcome
Okay.
everyone. So week two of our challenge. We got some questions already. Simon, over to you.
All right. So let's see. First question. I understand that transverse expansion is enough room for the four incisors, but I have several cases where the incisors are upped nicely, but we still don't have room for cuspids and canines and bicuspids. So am I correct to say that if the patient still needs more transverse expansion of the lower to fit the upper transverse width, then we would keep expanding the lower even though there is enough room for the four incisors? And once we've achieved adequate transverse expansion of the lower and upper, is there still not enough room for cuspids and bicuspids, then start reclining centrals? Can you please clarify? So obviously everything is just a general rule. Uh, Transverse dimensions are needed for the incisors. Um, you need AP for all the side teeth, and canines kind of sit on that boundary of being a front tooth and a side tooth. So we have to bear in mind that sometimes wide is not enough for the canines, and you need more depth. This is especially true if you've got really big teeth. Um, when you have enough room on the top, but you don't have enough room on the bottom, you got to keep expanding the lower until everything balances together. Yeah, absolutely. So the lower sets, the lower is traditionally in orthodontics called the anchorage arch. So the lower arch is the one that you have to build the upper to. The lower arch, because you don't have any potential realistically to expand skeletally, um, the maximum width of that lower arch is the reference point for the width that you need for the upper. Lower expansion is predominantly in the arch form. Sadly, in late mixed dentition onwards, you don't have as much room for growth compared to in primary dentition and early mixed dentition. So once the molars are uprighted at the back, you're kind of at the end of what you can do with the expansion of the arch. Otherwise, you'll start to tip the molars outside of the buccal um, bony um, system. So yeah, you develop the lower arch until it's nice and flat in the curve of Wilson, and then that becomes your reference point for the amount of width that you need in the upper. Once you have as much as you can achieve in the lower arch, then you expand the upper to cover the lower arch. And usually there's enough room for everything forward of the sixes to fit. But if there isn't, if you've got big canines coming through, then you have to start tipping the incisors forward to get some AP dimension. That's just how the body normally works. All right. So in normal good growth, the incisors tip forwards in an open bite relationship, so you get AP development, both upper and lower arches. Normally, the width of the natural good growing face is not quite enough room for the incisors to fit. So they come through very slightly ectopic in a proclined tipped relationship. And because they erupt slightly proclined, because the space is a little bit tight, then the time it takes for them to meet in the middle is extended compared to if they had plenty of room and they erupt vertically. That tipped relationship of eruption and the extended timeline of the eruption path before the incisors meet in an overbite relationship is what allows true mandibular rotation to give you adequate forward growth to develop a chin. So we encourage a slight proclination of the incisors in postural orthodontics because we understand the concept of true mandibular rotation, growing the most forward and upwards chin relationship during the mixed dentition time frame when the incisors first erupt, slightly tipped forwards, with an open bite that doesn't close for the next 2 years. So yes, you widen until you've got a flat curve of Wilson in the lower arch. You marry the top to meet a nice relationship with the lower arch. Then you start tipping the incisors to create an almost open bite. And then with strong posture, the roots talk forward and you get more AP and you get a little bit of chin development. All right, that's actually how, and you close the slight class 2-ish relationship that is normal in very, very young children. So all the protocols that I've designed, postural orthodontics, follows the good natural growth that happens in children with strong posture and allowing for true mandibular rotation. If you want to understand this, you have to go back and read all the papers that I asked you guys to read from Peter Bushang about true mandibular rotation and good natural growth. Okay, how do you manage cases where the lower arch is expanded more in the posterior region and the lower sixes are sucked in? However, the lower anterior region is still quite crowded between the Cs and the lower incisors. The lower arch development is not a skeletal development. All right, so the bone and the teeth move only when the appliance is in contact. So if you've got good relationship in the molars, but the anterior is still narrow, then you make a plate that doesn't touch the molars, and you just keep expanding the lower arch in the anterior region. Yeah, so you have a plate that doesn't extend to the sixes. You might still have a free wire rest that doesn't have any acrylic component to it, so that you've got some resistance form, but you don't have to have any transverse force on the 6-year-old molars. Or you can make a plate that stops at the E's, doesn't have any contact at all with the sixes. So then you can segmentally expand the anterior section and leave the permanent molars exactly where they are. Lower arch development is an arch development. It is not a sutural development. It's an arch development. And so you don't contact the teeth with your plate, and those teeth tend not to move. Next question. During this recent session, Candace had a patient with a lower plate that wasn't fitting well, and she said she took the plate. You recommended she leave the plate out for a few weeks, then turn it back and try to get it to fit. If it still doesn't fit, leave it out again and then have him turn it back again until it fits. I haven't done this yet. Can you explain the rationale of leaving it out and then turning it back to refit? He wasn't overexpanded, I don't think. So he was overexpanded. The molars were in a negative curve of Wilson, over-tipped, and so we're allowing for relapse. We never do this protocol of taking the plate out, letting it relapse, and then rewinding the plate to let it refit, unless we have overexpanded. So this is, it doesn't fit, it's overexpanded. Then you leave the plate out for a couple of weeks, let it relapse, and then rewind it back until it fits nicely. Then we check to see if you've had sufficient relapse. If you haven't had sufficient relapse, then you leave the plate out again for 2 or 3 weeks and let it relapse further and rewind it back until it fits. Then check to see if you've got the arch form that you want. If you haven't, you just keep doing it until it's relapsed back to a nice flat curve of Wilson. When that has happened, then you rewind it back until it fits nicely, and then you're done. Then you keep it in and hold that position static. So you missed the initial diagnosis and only heard the treatment plan. The diagnosis for Candace's case was that it was overexpanded and lower molars were starting to tip into a negative curve Wilson. So our goal was not only to let the plate fit back in, but we wanted to relapse back to flatten out the curve Wilson. And so that protocol of leaving the plate out, letting it relapse, rewinding the plate until it fits nicely again, and then repeating that until we have the right amount of relapse. So that protocol is to allow relapse to occur when we have overexpansion. Okay, that's all we have.
All right. Anyone else with any questions? Any follow-up questions, Dr. Dutton? All right. Any well, this is the week 2 of the challenge. Week 2, we're covering week 1 we covered all the GOPex, all the different lessons, the principles. And then week 2, Simon, we have evidence and clinical. So the part of the protocol was Stanford Ortho Airplay study outcome Texas. Anything you want to discuss there, or any quick summary, like the Stanford Ortho plate, how that what you like to share about that, and also the Texas A&M paper that was covered in this week's curriculum for the challenge.
So the Texas A&M research was based on my cohort of treated patients with bi-block orthotropics. And at the time, Professor Peter Bushang was the head of the department, and his interests in ortho is in the management of hyperdivergent or excessively long-faced children. And I had treated a lot of vertically increased or divergent growth patterns in my bi-block orthotropics cohort. So he was interested in assessing the outcomes. He assigned a master's student in orthodontics in his department to evaluate the cohort. And they selected 30 hyperdivergent patients and decided to do an analysis on the changes that occurred. And they referenced the French-Canadian growth cohort that is in the North American legacy studies of historical data collected in the 20th century of cephalometric analysis of growing children over many decades. And these growth studies were instrumental in helping us understand growth and development in children that were not being treated, and what happens in normal growth and development, and what happens in growth and development of children with various malocclusions. So that evaluation was done as a cephalometric evaluation, and it was predominantly a 4-year study of ceph analysis, comparative before and afters of my cohort, before treatment, after treatment, at the 4-year mark, and matched to hyperdivergent patients in the French-Canadian study that were also same age, same gender, same time frame. These are untreated children compared to my treated children. The findings came to the conclusion that there was some improvement in the vertical dimension at the end of treatment in comparison to hyperdivergent untreated growth. Not a huge improvement, but control and no loss or no increase in comparison with the untreated cohort. There was some forward momentum in the true mandibular rotation, not of huge significance, but some improvement. But there was some significant improvement in A and B in comparison to the untreated group, and there was a whole classification improvement from class 2 to class 1. So the conclusion was, although bi-block orthotropics' big claim is to reduce vertical, there was no reduction in vertical, but there was control of vertical. But there was a statistically significant reduction in AP, where the B point in particular, the mandibular growth, improved. And in the majority of cases, we were able to shift from class 2 skeletal pattern to class 1 skeletal pattern. Yeah, so that was the outcome of the study.
Now, we're not obviously with postural orthodontics teaching orthotropics, but it's can you kind of explain to those who are relatively new to postural orthodontics how what we're teaching is different from orthotropics and what was studied in that, Texas A&M paper.
So we were treating specifically significant malocclusions of increased vertical dimensions, divergent growth patterns that usually get worse in time, and orthotropics is the foundation protocol that I've modified to become simplified for postural orthodontics. And both systems focus on improving oral posture, changing from a slack, laxed, open mouth posture to a stronger, closed resting posture, effectively utilizing our understanding of true mandibular rotation, where infants are born with very weak chins to facilitate good breastfeeding with our teeth, and over time naturally develop a stronger chin until we become class 1 adults. That phenomenon of change from effectively what we call a skeletal class 2 baby to a skeletal class 1 adult is facilitated by strong oral posture, where the growth of the mandible, which is independent of the growth of the maxilla, develops to match in its growth by having a closed mouth resting posture. And the chin relationship is naturally dragged up and forwards in its growth pattern and path from infancy until adulthood. So that growth concept of how babies with no chin develop into adults with strong chin is utilized in postural orthodontics to rectify divergent growth patterns, such as hyperdivergence and significant class 2 relationships. And the same concepts, because it's a postural issue, can be utilized in less significant malocclusions for improvement of good growth, again, to reduce that class 2 tendency that is common in children hanging their mouth open. So postural orthodontics utilizes the understanding that posture can have a significant effect on growth and development. And so we focus on ways of using exercises to help change the posture, as opposed to in severe malocclusions, such as in hyperdivergent malocclusions, where we use appliances to specifically force a closed mouth resting posture. So in postural orthodontics, as we're dealing with milder malocclusions, we don't have to resort to more aggressive treatment approaches, such as in bioblock orthotropics. Instead of using appliances to force a child to stay closed, we encourage them to stay closed by improving their posture through exercises such as with the Good Oral Posture exercise program that we've developed, which is part of the 30-day challenge.
Terrific. Yeah. So we got another question from Dr. Dutton in the Q&A doc, if you could take a look at that. And also the Stanford. Why did you, include the Stanford, the SOAP program, and how is that kind of inspiring or relevant to what we're doing with GOPex and postural orthodontics and orthotropics, I guess.
So the Stanford Special Needs team
Mm-hmm.
had developed a appliance to help syndromic children with micrognathic jaws to convert their growth, which theoretically is genetically abnormal and theoretically remains genetically abnormal because of their syndrome, and changing their oral posture with an appliance at the infancy period, so the early years. They've shown there to be a significant change from micrognathic jaw development to almost normalized, if not normalized, jaw development in those early infant years. So again, we've got a leading institute, leading university, leading hospital system, treating syndromic children with effectively no lower jaw, using an appliance to change their posture, and converting their growth to become normalized and developing the jaw system to normalize within a very short timeline. So this is real world, high level clinical application of changing posture to change growth of the jaws, which theoretically is not possible even in non-syndromic children, let alone in syndromic children who has a genetic code for a short micrognathic lower jaw. So if you can take a syndromic child with a genetic code for no chin and develop a chin with just an appliance, does that not mean the environmental factors can supersede the genetic factors? So that's the significance of the information that is available at the standard SOAP protocols.
Yeah, very good. All right, so I've sent the Q&A Google Doc in your WhatsApp one more time. So if you open that up, it will be there in your WhatsApp.
Next question. Have you ever had a mandible arch that you treated in the mixed dentition that you wouldn't expand enough to meet the upper arch and therefore need to let upper relapse to marry the lower? Have you ever had a mandible arch that you treated in the mixed dentition that you couldn't expand enough to meet the... yes. Yep. So the lower arch is the anchorage arch. So when I was young and naive and I didn't understand life in orthodontics, in postural orthodontics, in orthotropics, I followed a script with zero understanding, but maximum adherence to the numbers. And, you know, I was told you got to expand to 42 mils, so I expanded to 42 millimeters. And then, you know, did what I told, follow the numbers say this, or 38, or whatever the numbers are. I would rigidly follow the numbers and not happy until I've hit that number precisely. And sometimes it was perfect. Sometimes everything was like rainbows, unicorns, fairy floss. Right? And then other times I hit that number precisely on the top and the bottom was teeny tiny and I was in a telescope bite, a Brody bite. And I found that I couldn't expand the lower sufficiently to balance that massive upper. And I had no choice but to relapse or retract in some cases the arch and the upper back until some semblance of occlusion was achieved. So yes, in the old days, I did it all the time because I didn't realize how stupid I used to be until I hit my head enough times on the brick wall. And then I realized most people's advice isn't worth the air that it takes to breathe for those words. And the reality is you have to be very mindful of the size of the teeth, of the size of the jaw, the size of the tongue, how much bone you have, what level of curvus bay you have that's compensated. And you follow the numbers, but are watchful for the true dimension of each child. You stop short of what you need to, and you work on the slower developing arch, which is the mandible. And the reality is the lower arch is the anchorage arch, and that sets the dimensions. The lower arch is what we reference. So we get the lower arch nice, and then we do what we need to make the upper arch fit that nicely. That is how you make sure that there is balance between the jaws.
Okay, very good. Any other questions? A few other participants, don't be shy. Anyone wants to raise their hand and join the panel, you can unmute and chit chat live or submit a question. See if there's anyone else who's got a question. Okay, let's see if there's anyone else checking. Otherwise, Simon will have a bit more lunchtime. Let's see if there's any other questions. Dr. Dutton, I know you've got always at least 3, 4, 5 questions for us. Much appreciated. Dr. Venneberg, any questions? Anyone from anywhere? Oh, welcome, Dr. Tang, Dr. Cheng, Malaysia. Thank you, Dr. Dutton. Any other questions? Going. Oh, I think something came through. No, that was just a thank you. All right.
Right,
Simon,
I'll sign off.
yeah, thank you so much. I'll stay
Thanks
on
so
and
much
answer any questions about
for
the challenge. But yeah, so next week the curriculum for those trying to complete the CE is on case presentation. So that's a fun one. Get to see Simon going through many different cases. So that's the curriculum. Anyone wants to ask a question about the challenge? I'm going through this challenge with my two boys right now, specifically while they're having the upper and lowers expanded, and it's been a challenge. I'm fortunate to homeschool my kids with my wife, and but still, it's a challenge to do these exercises. And we've, you know, at least been, and I'm trying to show by example here, right? So with different things popping up in life, if we can actually do at least the smile exercise in the morning or the evening, most of the times the morning, and then there's the counting and chewing, which sometimes we miss in the morning, and then we have to make up for it in the evening. So don't feel bad if you haven't been able to follow every day, at least the twice a day routine. Like today, we had to visit Dr. Rose, who's we needed to take a look at the lower fillet because we've been having a lot of issues because his six is erupted. Right? This is one of the things that we generally Simon says to avoid is during that for 6 year olds when their sixes erupt, um, it can affect the appliances, and that's in our case they erupted just as we got the appliances, so we gave it a shot, and it was really painful, and then we had to go back, and unfortunately we're not across the road. It takes us an hour and a half to get there. So yeah, it's been challenging to get the lower in. So we're still trying to figure out whether we just wait until the six is completely erupt. Um, but it's either been too tight and it's been too painful, and because I think everything shifted, That's my understanding. Gonna get Simon to take another look at it. But during all this, we're still trying to. We were at lunch today, just after the appointment, and that's when we did the GOPex chewing. And so, because we were rushing to leave in the morning, um, so we managed to do the exercises at the restaurant. So you can do them anywhere. It doesn't have to be morning and evening, as long as you do the reps at some point during the day. It takes 2-3 minutes. You can take it off. But that's life, the modern life that we live in. But anyone like to share their insights, their challenges, their epiphanies? Any? Um, my boys seem to like the inner smile thing. It was something that I added. It wasn't in the traditional GoPex, but they enjoy it, and they enjoy the smiling exercise because I think most of the time they're pretty shy when they're young, and my boys are 7 and 8, and the younger one still, is not as natural a smile as the older one yet. But so it's fun to play with that smiling game. Little smile, open smile, and then remind them what the proper oral posture is. And then when they close their eyes, they're mindful, and then they can do that inner smile exercise where they're smiling into their different organs and transferring warm, fuzzy, positive vibes throughout the whole body. And then they're open, and then they can put a big smile on, and they enjoy that. So it doesn't take more than a minute. It can be very short, but it's one of the nice routines that we're doing now. Um, so yeah, it's been a fun and challenging process. Anyone? Oh, we've got a question. Dr. Chang, I'm practicing counting on my 27-year-old son. Fantabulous. Some days he will sit on the chair, some days lying on the bed. That is hilarious. That is fantastic. Thank you for sharing that. You know, so very typical, Asian household, very traditional. 27-year-old son still staying at home. And mind you, here in the West, the studies are showing that, more and more children are decided to hang around with their parents' houses because it's too expensive to live anywhere else. So, woohoo, way to go. Back to tradition, extended families. So yeah, you don't have to practice on a 7 or 8. You can have a 18-year-old, 27-year-old. Okay, I find if the families give incentives, prizes, the kids get really excited about it. Fantastic tip there. Thank you. Like calendar with extra points if the kids remind the parents versus if the parents have to remind the parents. Kids remind the parents. Okay. Oh, parents have to remind the parents. Got it. Got it. Actually, yeah, look, anyone wanting to share and join the panel, that would be fantastic because this is what it's about. I mean, the appliances are relatively, for Kai, it's, oh, I'm on. What am I doing on camera? Actually, let's have a look. Uh, if anyone wants to join the panel, feel free to raise your hand, and more than happy to have you join and share rather than type. But if it's late at night and you're in your pajamas, you'd like to stay anonymous, not a problem. But yeah, it's what were we talking about? Yeah, the challenges of doing this routine. The appliances are relatively easy. If we're there to help clean. More often than not, we prefer to make sure that we do it properly. But it's that habit, getting the kids to do these counting and chewing exercises every day in, day out. And if you can do it for 30 days, you can do it for 6 months, you can do it for a year, and hopefully it'll become more subconscious, right? But I like this prizes sort of thing. Sorry if the parents have to remind the kids, yeah. As long as he's doing it, it's okay. Absolutely. Yeah, it's fun to have, make gamify it, as they say. Especially kids. Kids love games. So that's a good thing. Definitely a good tip to gamify having these exercises done. Excellent. Thank you for sharing that. Anyone else who had an interesting breakthrough or just being more conscious yourself about tongue posture and so on and so forth. Dr. Ku, welcome. Dr. Hazel. Anyone else? Anyone? I mean, there's a few of you guys who've been doing this for a few years. Any tips on GOPex? Any other insights? If you want to raise your hand, join me on the panel. I'll turn on my video. Kind of incognito at the moment, but happy to. I'm a bit shy myself. All right. Any other final questions going once? Now we've got now as with the CE. Those of you who need and want the PACE AGD CE, just complete the 6-7 hours before the end of the 30-day challenge. We started August 3rd. We'll be sending email reminders. The midway mark is coming up very soon. The quiz is very simple. If I can complete it, I'm not a dentist. So can you. You can do it many times, and then just email us, and we'll get you the CE. And in worst case, it takes you an extra month to get it all done. Then I think it's an extra $30 or something penalty. Nothing to worry about really. But try to get it done in 30 days. That's part of the challenge. Alrightio. So on that note, if we don't have any, oh, there's another comment. I did counting exercises on video call with my grandnephew 2 days ago. Thank you, Dr. Chen, for sharing that. You can do this virtually. I was going to suggest that tip for those who don't have young kids at home. You can do simple counting, conducting exercises with your grandnephews even. Or grandkids. Or maybe you only have grandnephews for now. But thank you. That's excellent. Oh, Dr. Cheng, you had submitted a case review. Yeah, do contact us about that whenever you're ready. Yeah, so for those of you who would like Simon to review a case, it's pretty straightforward. You just send us an email and we can send you the instructions on that. I'm going to share my screen. Yeah, so you just submit the records, the usual pediatric sleep questionnaire, the one that Simon created, orthodontic photo panel, PanX, OBG, or lateral ceph, and you can add a couple of questions in the email or the presentation file, or whatever. And then Simon will get back to you, review it, and then record a 10-15 minute video going through the case and explain what his thoughts are on in terms of. It's not a formal diagnosis as such. There's only so much you can do in 10 to 15 minutes, but definitely can explain whether he feels it's suitable for postural orthodontics treatment, what type of malocclusion it falls under. So it's more of a guidepost to give you a thumbs up to either do it yourself or have Simon guide you through that process. And the main thing is, a lot of people think, oh, do I have to learn orthodontics and stuff? At the end of the day, even though we call it postural orthodontics, it doesn't take you that 18, 24 months like a POS, progressive here in the US. It takes you quite a lot of hours to learn, obviously, orthodontics. You're not at university setting as such. A lot of these, my brother went through that, took a couple of years to learn how to put on braces and whatnot. Here, it's a very specific protocol. It's about figuring out how to use these removable appliances that Simon developed, modified off of Professor John Mew's BioBlock, and developed the lower appliance off different inspirations over the years, and coupled with the GOPex exercise. But it's obviously, how do you design? How do you diagnose properly? How do you case select properly? And if it's your own child, it's just one type of malocclusion, so it's relatively a lot more straightforward than implementing to your own practice, right, where there's many different types of malocclusion. So for parent dentists, it's a lot more straightforward, but you can join the mentoring program still and have it, guided by Simon over that period. And so that's something that is a new thing. Dr. Cheng said, will Simon help with appliance design in the case submission? That's a separate thing. Just to be clear, we do have a separate fee for appliance design. So it's a standard fee, $200. for upper and lower. We've been having it for quite a few years now, and we have dentists around the world who've done the 2-day program. They may not have even done the advanced course, and they just order the designs. They know basically how to implement it, but there are nuances into how to design things properly, right? So knowing what to clasp and whatnot, and Simon's really good at it, so people just order that. So you can have that ordered. So that's something that can be done. If you go to /design, posturalorthodontics.com/design. So posturalorthodontics.com/design. All the instructions are there. So that's a separate service. He doesn't do that as part of the case review. All right. So, not if you join the mentoring program, then he does it for free. But if you're not part of the mentoring, then it's a separate fee. Rightio. So, thanks for bringing that question up. Okay. Let's see. Any other final questions? Otherwise, we'll wrap up for this evening. Okay. Thank you for yes. Do give us feedback on the GOPex on anything related to the challenge. I know for some of you guys it's a refresher. For some of you guys are new, and we have during the Q&A time a lot of questions coming in are from advanced students and mentees as well. So you get to hear what they're going through, which is always interesting. And then they have their formal mentorship calls over the weekend every 2 weeks. Simon's on for about 5-6 hours, answering lots of questions, going through cases. And we've given you a sampling of that inside the challenge. So that's after the first 4 weeks of curriculum. There is the case supervision sampling. And you can see about 50 minutes worth of the mentorship calls that happen. About 7 examples, 5 different dentists. Cool. All right, on that note, I'll say sayonara, good night from New York, and we'll see you next week. All the best for the GOPex challenge. Good night. Bye.